This is Bubble Genius, and we approve these MOMocrats.
I'm not going to lie to you. The news this summer has been uniformly awful. War, disease, police brutality, and the loss this week of one of the few people who was really good at getting us to laugh through the tears. Welcome to MOMocrats Mama Chat, brought to you by BubbleGenius.com. I'm Donna Schwartz-Mills, and we're going to break format just a little bit today to accommodate our guests who are here to tell us a little bit about a new California ballot initiative that, on the surface, sounds like a good idea by requiring doctors to submit to drug and alcohol testing. But like most proposals in our modern, money-soaked political process, Proposition 46 is not what it seems. Joining me to talk about it are Cathy Frey, CEO of the Central Valley Health Network, and Terry Holloman, a Democratic Party veteran consulting the No on Proposition 46 campaign. And good morning, ladies. How are you?
Good morning. Thank you. Very well.
Good morning. Good morning. Thank you.
So which one of you is Terry and which one of you is Cathy?
I think I'm Terry this morning. It was a long night last night at the LA County Democratic Party, so I think I'm Terry this morning.
Okay.
And that makes me Cathy.
Hi, Cathy.
Good morning.
So anyway, you know, ballot propositions were designed to give the public some say in what's happening with the legislature, and it appears that it's something that's totally democratic, but over the years it's become just another tool for big money special interest groups to warp the process. Tell me about Proposition 46.
Certainly. Well, Proposition 46 is called the Troy and Alana Pack Act, and the proponents of the proposition have designed a three-part proposition that attempts to address patient safety, is what they would say. And there are three elements to it. The first, as you alluded to earlier, is drug testing for doctors, which, as you said, on its surface would not necessarily seem to be a bad thing. But as with most ballot propositions, and this one in particular, the devil is in the details. And so the way that they have laid out this proposition does not allow for any flexibility. So, for example, one of the elements of the proposition is that, with respect to drug testing, is that a doctor must show up within 12 hours of any adverse event. That means whether it happens 2 weeks from now, 2 months from now, 2 years from now. And if they don't, they can lose their license. Well, show up for drug testing. Well, you know, that's a problem, obviously, if a doctor is in surgery and can't show up within 12 hours, if a doctor is traveling and can't show up within 12 hours. And the initiative specifically says requires, or if they fail to comply, they can lose their license. The ACLU opposes the drug testing element of the initiative, partially because of the randomness of it, that it's suspicionless and it's random. And the proponents have said that it complies with the FAA guidelines for pilots and other airline personnel. And what is deceiving about this is that it targets doctors specifically. And I would not necessarily advocate, I have my own personal views about drug testing, so I would not necessarily advocate for this. But what's interesting about it is that it doesn't address the entire chain of patient care. So it doesn't address people who handle intake. It doesn't address LVNs or RNs or nurse practitioners. It doesn't address any other healthcare personnel. It just targets doctors. And that's why it really gets to the heart of what this initiative is about, which is MICRA. And that is, it's what, if they were going to put together an initiative, it's what it just should have been about. They have three separate things in one initiative. And MICRA basically deals with what is commonly referred to as pain and suffering. And so, so please stop me if I'm rambling. This is my first podcast, so I'm excited and a little nervous.
Well, let's talk a little bit about MICRA, because MICRA was in itself a reform that was enacted for the first time Jerry Brown was governor, correct? On malpractice suits?
Correct.
Yes.
So a little
Cathy,
history.
Sure. Cathy, I defer to you on that.
and it's not because I was in the business when Jerry Brown was first, when he was the first governor, but living and breathing in the healthcare world for over 25 years, yes, MICRA first came into play, and it really was as a result of what at the time, now this was 35, 40 years ago, well, Jerry Brown 35 years ago. At that time, the malpractice insurance rates here in California were ridiculously high, and it was driving providers out. And as a matter of fact, there was a severe shortage of OBGYNs. Docs didn't want to come practice in California because the malpractice insurance rates were just ridiculously high. And as we were, at that time looking at a severe physician shortage, there was they call it the napkin deal, but there was an agreement that was made, and that's how we had MICRA, which basically, which stands for the Medical Insurance, something reform. Sorry, it's early morning, and it's been my commute this morning was challenging at best. But the bottom line was what that did is it limited the pain and suffering awards to $250,000. Now, it did nothing with any any of the other because there's multiple components to malpractice insurance awards, and pain and suffering is only one piece of it, but certainly, bills or any kind of award that would, pay for someone's ongoing treatment as a result of, malpractice, those were not included in this. This is just the pain and suffering. And so what this initiative really has, what it started out as really is how can MICRA, the cap on MICRA, which that cap is $250,000, how could that cap be eliminated? Because as the proponents are stating, that was 35 years ago. If it were adjusted for inflation today, it would be $1 million. That's really what this ballot initiative is all about, is really trying to eliminate that cap so that, in essence, attorneys, particularly trial lawyers, have their fees come out of that pain and suffering award. So one can draw some conclusions there, but that's what this is all about. The other two pieces of which Terry talked about, the drug testing, but then the other piece of this that got thrown in there was the mandatory use of what's known as the Cures database.
And if I can interject, I think one of the things that's really important for your listeners or participants is, to understand kind of the stakeholders on either side. And as Cathy alluded to, this is a bill that is sponsored by California trial attorneys. From an opposition perspective, in addition to California's doctors and dentists and community clinics, our coalition is incredibly broad. It includes ACLU and Planned Parenthood of California, clinics such as those that Cathy represents, as well as California's teachers, SEIU, AFSCME, a number of members of organized labor. And so we have a broad coalition of over 600 people, 600 organizations, who oppose the initiative. And part of the reason, as Cathy said, is that on its face, this all seems to make sense. So increasing pain and suffering awards would seem to make sense. And there are some members of our coalition who might be open or amenable to that. But I think Cathy can talk more about the impact to clinics, but particularly the drug testing component, which we talked about. One of the things that has been most shocking about that is that if they were serious about putting together a drug testing program under the guise of patient protection, they would not have made a comment that has been reported both in the LA Times and the New York Times, in which they, when asked why they included drug testing, they specifically said because it polled well. And so it speaks to your point about initiatives and the politicization, I can't talk this morning, but of initiatives. And so it really is about MICRA. And so Cathy can really talk to you about the impact to clinics, but I think from a political perspective, that's what is so objectionable to people, is that they're playing politics with the issue of patient safety.
Yeah, absolutely. I mean, Terry, you said it just perfectly, that no one is against patient safety. In any of the healthcare settings, that's just it's a proponent. It's just so important to us. But when you really pull apart, like an onion, and you pull apart all of the layers of this thing, and particularly when you hear someone say, well, this tested really well in a focus group, so we're just going to throw this into this pot of something, of an initiative that we're trying to put together, which is the drug testing. I personally hate initiatives. I think they have completely taken over the way we legislate, and in California. And California is the butt of the nation when it comes to you legislate by initiative. So personally, I think initiatives are just a pain, and I just abhor them to begin with.
But I'm with you. I don't sign the petitions anymore because you don't really know what you're signing, and I go just to vote against them.
Well, I think that's a lot of what the populace is. I think Californians are just frustrated with just the number of initiatives that are on the ballot. But this one in particular, if it, on the face of it, if you just read it and and it's like, oh well, drug testing. Well, I'm a I work at Home Depot and I have to be drug tested, so why shouldn't my doctor be drug tested? It's much more complicated than that. Same with, because it's not just about drug testing. It's also about the mandatory use of a database to check every time you would go in. I mean, if this initiative were to pass and become law, the very next day, which I believe is either November 4th or 5th, I'm not looking at a calendar, that everything that's in that initiative becomes law because the proponents didn't put any kind of timeline into the initiative. So that's an important thing for people to understand. So you go to the doctor the next day, all of a sudden there's this thing called the Cures database, which is currently in practice. Our physicians and providers at community clinics and health centers all over the state use that. It's a voluntary database. We want to make sure that, if a physician is concerned that someone is somewhat doctor shopping or just looking for drugs, the Cures database in a voluntary way works very well when it works for the provider to understand, well, you've had 5 prescriptions for Vicodin over the last 2 days. There's something not right here. But what happened, that's voluntary right now. The day after the election, that becomes mandatory. So that means if, any of your listeners, they go to the doctor the next day, they've got a bad back, they've had that horrible cough, and the doc says, well, probably need some Tylenol with codeine. That doctor is going to have to check the Cures database to make sure that patient has not had Tylenol with codeine, sometime in the, whatever time period it's been. It's not going to be voluntary anymore. So those of us who have, our kids, our, us, moms, dads, all of us, people who are, just need pain medication because sometimes you need pain medication, you're going to have, the Cures database is something that is going to be something not only your doctor is going to have to look at, but when you go to fill that prescription, your pharmacist is going to have to take a look at it too. And that has some real implications for a couple things. One, some privacy issues are at base because that database is kind of run by the state of California, and I am concerned that anything run by the state of California can have challenges, especially when something becomes mandatory, not voluntary. So you've got a couple 100,000 people now trying to check a database at the same time because it's not just at your doctor's office, it's at your emergency room visit, it's at your dentist, if you're at your veterinarian and your dog needs pain medication, your vet is going to have to check the Cures database.
Oh, really?
and really. And but because there hasn't been any thought into how to implement this, there was no timeline of by December 2015 or something. That's the frustrating part of this. No one's suggesting that the Cures database isn't a good thing. It's just how it's been laid out in this initiative, which just brings to point the whole problem with it. Terry, go ahead.
Right. I'm sorry, this is so unusual for me because I've not done this before, so I don't want to at all interject inappropriately. But I think what's important to understand, in addition to what Cathy said about the database, is the fact that it is administered by the Department of Justice of California. And as a result, the Department of Justice has looked at their own database at different points in time over the past couple of years, and they have said that it's slow and it freezes. And one of the things that's compelling about this is that because it requires a doctor to check the database before prescribing a Schedule II or Schedule III drug, and it's slow, and it freezes according to their own analysis. And a more recent analysis, and a more recent analysis as of 2 weeks ago, where they have said that it may not occur in real time, the transactions may not occur in real time. You couple that with the fact that there is no new funding in the initiative to support the database and the entrance of, these couple of 100,000 of new patients or folks into the database. And it again speaks to the fact, as Cathy was alluding to, it's not well thought out. And while it's well-intentioned, and I think it's important for us to be as transparent as we can about this, that there are a number of, as Cathy said, clinics and health centers and doctors who believe in the concept of the Cures database, so much so that doctors have helped to fund the database. But when it's not functional, and then when the consequence is that, according to the way that the initiative is written, when the consequence is that a doctor can be cited for not checking the database before prescribing a prescription, and it puts doctors, physicians, dentists into a place of having to choose between retaining their license or not, getting dinged by the medical board, and prescribing to their patients and patient care. And so, as you said, from an initiative perspective, part of the problem sometimes with initiatives is that there are unintended consequences. And if it's not spelled out, as Cathy said, it becomes effective the day after the election because the proponents did not put a timeline in there. And so doctors and dentists and healthcare providers are put in a situation where they could be in violation of the law if they prescribe without checking the database, and the database isn't functional. So that's the nuance about Cures.
Right, and there's no funding included in here to upgrade the database. So we can have a situation. I mean, last week my daughter had her wisdom teeth out, and her dentist prescribed Norco for her. Next month, I am going to have some surgery, and in this situation, the doctor could look at the database and see that my daughter was prescribed Norco, and there could be questions about giving me pain medication for my surgery?
Well, I think that at the extreme, yes, but chances are your provider knows you, and and that's where that doctor-patient relationship is so important. So, but what if your doctor wants to prescribe that pain medication when the Cures database is down? He or she is going to take that, have to take that potential risk of, well, my patient needs this. In the best interest of patient care, I'm going to prescribe this medication. But if somebody questions that after the fact, I mean, it's like, well, they risk potential backlash from the medical board, or somebody's going to question them, and it's really all they are doing is really what's in the best interest of the patient. There's one other twist to the Cures database that is a little alarming. It's a foregone conclusion within the state of California. We have a number of people here who are undocumented individuals, and the health centers that are part of the Central Valley Health Network, we're in the Central Valley of California. Very much, it's about farm workers and agricultural workers. You could do a whole show on the what those folks really provide to the economy.
Really?
However, the Cures database is, as Terry pointed out, is going to be housed and monitored by the Department of Justice. And everybody, right, community clinics and health
Department of
education.
Justice?
Correct.
So wait, but this gets worse. So in community clinics and health centers throughout the state of California, we see everybody regardless of ability to pay. We don't care whether they're documented or undocumented. However, if that provider is now going, if this becomes law, that provider would have to check the Cures database, which means that person's information is going to go into that database. ICE, which is the immigration folks, could potentially have access to that database. It's not going to take very long for the word to circulate throughout those those communities that, well, if you go to the doctor, they're going to put your name in something, and and immigration could come call. It's taken us as health centers years to help our patients understand that when we use an electronic health record, that's not going to anyone. It's not
right.
It's taken years to help folks understand when we're trying to enroll either them or their child into health insurance. ICE can't look at that. That's not the case with the potential with Cure's database. So that is a concern and something that is, again, not been really well thought out in this initiative. I think that as it stands right now, the Cures database, our health center providers do use it. And they use it when they are suspecting somebody is, coming in and getting multiple prescriptions for Vicodin or Norco or whatever. But November 4th, it becomes law, and it's not just doctors. It's nurse practitioners. It's physician assistants. It's pharmacists. I mean, in a health center, there are physicians, but there are also a whole host of other medical providers who provide care that would be required to use that database. So now you're looking at, thousands, hundreds and thousands of people trying to access something at the same time. And I think that's a big one. There's one
I think the recent experience of the Obamacare database when it went live before it was ready.
Yep.
We all remember that.
Yes, and I think it's a really important thing because again, I think there's other issues that we need to talk about. One, to Cathy's point about the Department of Justice administering it, what is also true is that they have said that patients have no reasonable expectation of privacy. Very different than healthcare providers, which have to comply or who have to comply with HIPAA. Because it's administered by the Department of Justice, they don't have those same requirements. And so that's, something that's very scary. But to your point about Affordable Care Act implementation, one of the things that people have said, because we've been traveling the state talking to people as recently as last night, as I mentioned, at the LA County Democratic Party. And one of the things that people have said was, well, hey, there were challenges with ACA implementation, but it doesn't mean that it was a bad thing. And that's absolutely true. What is also true, and was more true in this case, is that when you start talking about provisions of an initiative that can cause medical providers to lose their licensure as a result of something not being fully formed and cooked, that's a different situation than just technical glitches,
Yeah.
And I think that's the cogent point here, is that this initiative, and if I may, one of the things that the proponents say, and I think it's important for us to have this as part of the discussion point, one of the things that the proponents say is that, there are roughly somewhere between 40 and 50,000 people in the state of California who are victims of medical negligence in some way, shape, or form. And that is something that needs to be addressed in thoughtful deliberation, not in an initiative that is thrown together with unintended consequences. Yeah. But one of the other things, and I think this is what Cathy can really speak to, is the fact that in California there are 5.4 million people who use community clinics and health centers for their primary and preventative care, the majority of whom are women, the majority of whom, and by majority I mean somewhere in north of 3 million, the majority of whom are people of color, somewhere probably closer to 3.5, 4 million are people of color, and people who are, so I think 65% or 100% are below the poverty level. And so when we talk about the impact that this initiative has, that's the population that's most impacted by this initiative. So that's just an important point to make.
Right. There's one other big piece, and I know we're running out of time, but I think it's important that folks also understand. There's an access issue here as well, and it has to do with the fact if the MICRA cap were to be increased significantly, the malpractice insurance companies have no choice but to increase their premiums. They don't have a choice. They're going to have to do that. Community clinics and health centers, and a whole other show on how they buy malpractice insurance. But just put it this way: there's about 1,200 community clinic and health center sites in the state of California, and almost every single one of them has to buy, in some way, shape, or form, malpractice insurance on the open market. If those premiums go up, there could be consequences to very small community clinics and health centers that see their premiums go up to the point where either they're not going to hire another doc, they're not going to bring on, they may end up having to reduce services. And I'm talking very small health centers in rural parts of California where they're the only provider of care. And if they have to reduce their hours of operation, or they can't bring on another provider because they can't afford what the malpractice premium is going to be, that could definitely seriously restrict access to just primary health care for those individuals. And I think it's just important that, and I know the proponents say, well, every clinic and health center in the state of California has a federal, they're eligible for this federal, Tort Claims Act. They can get it. That's not true. I guarantee you that's not true. But that's another important, I think, just element for folks to understand. So when you put all this together, this initiative is just fraught with all kinds, I think, of challenges. It's just not well thought out.
Yeah, and to Cathy's point, and I think that if you look at this from a political perspective, because I think that that's part of what you were alluding to early in the conversation. If you look at it from a political perspective, the trial attorneys have traditionally been vanguards of the Democratic Party, especially in California. I can't speak for the rest of the nation. And what's telling about this is that people who traditionally would have been allied with them, whether it's organized labor or ACLU or Planned Parenthood, have all joined our coalition. And I think that requires, it requires people who are voters and who are, thinking participants in the political process to really ask the question why. And it's because it's poorly put together as a matter of public policy. Again, it's well-intentioned, and I don't think that there's a single member of our coalition, I think I could say this, although I never speak on behalf of them, that doesn't care about patient protection, that doesn't care about patient safety, and that doesn't care about health care in the state. But because of the unintended consequences, that is why our coalition is so broad. And that's why, if I may, last night I alluded to it twice, but we're really proud of the fact that the Los Angeles County Democratic Party is, as everyone probably would know, Los Angeles is the largest county in the state of California. That's why they chose to oppose the proposition last night by over 75% of the vote, because it's not in keeping with democratic principles, partially because of the way that it impacts women. As Cathy alluded to, the restriction in access is principally to doctors like OBGYNs who can't afford, who will not be able to afford to practice. And so when you look at this from whether it's a political perspective or a public policy perspective, it just doesn't make sense.
Well, again, this is what we say in just about every MOMocrats podcast. You guys, you got to vote. You got to go to the polls. It doesn't matter what kind of an election it is. It doesn't matter if it's, for the dog catcher. It doesn't matter what it is. You need to vote. You need to get in there, and you need to look at these ballot initiatives, and you need to cast your vote. So Cathy and Terry, I am so grateful to you guys for joining us and putting a spotlight on this particular ballot initiative. I'm hoping that we can look at some other proposals and candidates as we head to the November elections. And where can our listeners go for more information on Proposition 46?
Terry? Yeah, I'm still here. I'm sorry. They can definitely visit the No on Prop 46 website. It's www.noon46.com. And there's information there. They can sign up to join the coalition and just find out a little bit more information about the proposition. All right. Well, thank you so much, ladies, and good luck.
Thank you.
Very much.
Okay.
We appreciate it.
All right. Bye-bye.
Bye.
Thank you. Bye-bye.
Hey, so Cara Lee's with us now. Good morning, Cara Lee.
Good morning. How are you?
I am well. That was quite an education on what this proposition is going to do. And I'm really grateful to Terry and Cathy joining us to talk about it. And it really does drive home, how we have to just get out there and vote, because that ballot proposition process just makes me crazy.
Oh, it makes me crazy, too. It's funny. I was approached to sign a petition to get that on the ballot, and I just instinctively don't sign petitions, especially when it's clear that they're professional gatherers,
yes.
you know. So,
yes.
I mean, I didn't even stop to listen to what they were telling me this wonderful thing was. I just, you know, no, I'm not signing it, goodbye, and moved on. But in hearing about how awful it is, I'm sorry to see how many people did sign it. That's too bad.
Well, you know, who doesn't want patient safety? As they said earlier, they focus tested it, and people like the ideas of getting physicians drug tested, and that's what they've led with all of the other stuff buried within. So, bad proposition. Vote no. And and now that you're here, I guess we have to turn our attention to all the awful news that we've heard this week.